Updates in women's health. This is a monthly live stream. We host this the second Tuesday of every month. We welcome different physicians to share and present on various topics. So if you'd like to visit us again, just be sure to visit our website. That's nortoncme.com. You can just remain updated there on upcoming speakers and additional information. Now, we'll let you know that at the conclusion of today's presentation, we will have an evaluation, and we do ask that you complete that evaluation to receive your credit. There will be a slideshow at the very end, which will post a QR code that you can just scan with your phone. It will route you to that evaluation, or you will also be emailed a link in which you can just complete the evaluation there as well. So today we have with us Dr. Amanda Caricato and Dr. Sarah Callahan. Dr. Amanda Caricato graduated from the University of Kentucky College of Agriculture with a bachelor's degree in animal science. She graduated from medical school and completed her internship, residency, and breast fellowship at the University of Louisville. Amanda started with the Norton Healthcare Breast Program in January of 2020. She's married and has 2 children. She enjoys reading, cooking, and playing pickleball. Dr. Caricato has no relevant relationships to disclose at this point. Now, Dr. Sarah Callahan graduated from Transylvania University with a bachelor's degree in biology. She graduated from medical school at U of L, also completing her residency and fellowship there. She's currently the director of breast radiology and mammographer at Norton Brownsboro and Norton Pavilion Breast Centers. She is married with 4 children and 2 dogs. She loves photography, traveling, cooking, and spending time with her family. She's currently the director of breast radiology and mammographer at Norton Brownsboro and Norton Pavilion Breast Centers. So with that, I will hand it off to you, Dr. Callahan and Dr. Caricato, to begin. And I believe you're on mute. So if you just want to make sure that, and with that, before you do start, this is a good opportunity for me to point out to the people who are joining us today, just double check, make sure that you are in fact muted so that we don't interrupt today's presentation as they speak. Okay, thank you.
Hi again, I think we were muted. All right, and I'll be starting today the first part of the lecture, which will be going over breast cancer screening and guidelines. So when we talk about breast cancer screening, a history of it, how did we get to breast cancer screening? And actually scientists early on realized that X-ray could be useful for the diagnosis of breast cancer. And in 1913, Dr. Albert Salomon studied mastectomy specimens with X-ray, and he realized the usefulness in the patterns of disease and actually spread to lymph nodes. In 1930, Dr. Stafford Warren studied 119 patients with X-ray preoperatively, and he concluded that X-ray could often reliably predict the pathology between benign and malignant disease. And it was revitalized in 1949 with Dr. Raoul Leborn, who reported radiographically visible microcalcifications in 30% of breast specimens, and that set the stage for screening mammography. He also realized that compression was important for the X-ray. In 1960, Dr. Robert Egan at MD Anderson actually developed a reproducible high MA, low KVP technique that optimized imaging for the breast. And then in 1963, the Cancer Control Program of the United States Public Health Service sponsored a conference at MD Anderson amongst 24 institutions and reported the usefulness of mammography in breast cancer. And that kind of got the whole ball rolling. In 1963 to 1966, Drs. Strax, Venner, and Shapiro, under the guise of the Health Insurance Plan of New York, operated the first randomized controlled trial of breast cancer.
Is the screen not sharing? Hold on.
No, your screen is not sharing.
Okay, hold on.
Go back and start. Escape, hit escape.
Webinar.
Again, everyone, if you'll just use this as an opportunity to double check, make sure you're muted. A reminder that we will have an evaluation at the very end of the course. You'll be shared a QR code that you can scan with your phone. A link will also be emailed to you, and that's how you will receive your credit upon completion of that evaluation. Now, as we proceed throughout this presentation, if anyone has any questions along the way, just be sure to write those questions, type those questions in the chat box below, and then we will answer those questions at the very end.
All right, I think I'm sharing now. So Doctors Straxmanier and Shapiro, under the Health Insurance Plan of New York, actually ran the first randomized controlled trial of breast cancer screening with mammography and evaluating cancer mortality rates. And at 5-year follow-up, the results of that study showed that compared with the control group, the mortality rate was reduced by almost 1/3 for the women that underwent screening. And in the late 1960s, Dr. Strax actually operated the first mobile screening bus, and there's mobile screening buses all over the United States now. The next decades actually are improvement in technology. In 1973, DuPont actually marketed the first dedicated screen film mammography system. In 1985, Tabar publishes data from screening over 134,000 women ages 40 to 79 with single MLO views only, and demonstrated a 31% decrease in mortality. And in 1992, the United States enacted MQSA as law to ensure that all women had access to quality mammography for the detection of breast cancer in its earliest stages. And in 2000, the FDA approval of digital mammograms, and then in 2011, the first digital breast tomosynthesis unit was approved. So from 1913 to 2011 and beyond. This is a picture of the early screening bus. It actually doesn't look that different from some of the buses we have today, just an older version, but they're pretty similar, and you'll see the ones around town. So breast cancer screening, why do we screen for breast cancer? The biggest risks for breast cancer are female gender and age, so it affects a big portion of the population. Breast cancer is the most common cause of cancer in American women after skin cancer, and breast cancer is the second leading cause of cancer death in the United States, with lung cancer being #1. The American Cancer Society statistics for 2020 estimate that over 276,000 new cases of invasive breast cancer will be diagnosed in the US this year, and over 48,000 new cases of carcinoma in situ will be diagnosed in the United States this year, and over 42,000 women will die of breast cancer. So early detection of breast cancer decreases breast cancer mortality. And while breast cancer incidence is up, death rate has decreased since 1988. This is likely due to improved screening, and then also better treatment. So mammography screening, it's not a perfect tool, but it does meet all 3 criteria. It's effective, widely available, and it's relatively affordable. Breast cancer screening recommendations. So recommendations vary by society groups, which actually causes some confusion. The United States Preventative Services Task Force in 2009 actually recommended biennial screening for women ages 50 to 74, which was a change. The American College of Radiology still recommends annual screening mammogram beginning at age 40. ACOG recommends to offer screening beginning at age 40, but to recommend screening at age 50, annual or biennial, and continue until age 75, and then discuss discontinuation depending on a patient's health. And the American Society of Breast Surgeons recommends average risk women should start screening at age 40, and high risk women should start earlier and be offered additional supplemental imaging. And then American Cancer Society recommends annual mammogram beginning at age 45, but you can change to biennial at 55. But they say that women who want to start annual mammogram earlier at age 40 should have the choice. So kind of all over the map there. The American College of Radiology estimates on their website that if patients followed the United States Preventative Services Task Force guidelines, it would result in up to 10,000 additional and unnecessary breast cancer deaths in the United States each year. And they also predict that following those guidelines would also likely result in more extensive treatment from surgery, chemotherapy, and radiation. This is a radiology talk, so we'll go with the ACR and Society of Breast Imaging guidelines, which their recommendation is a risk assessment for females by age 30 and starting annual screening mammogram at age 40 for the average risk woman, and to continue as long as they are in reasonably good health. So it's pretty simple for an average risk female. The annual screening mammogram is recommended to begin at age 40. And really the only choice is between digital mammogram versus digital breast tomosynthesis. So just the regular old 2D mammogram is lower in radiation, it's a slightly lower cost, and it's a faster interpretation. Digital breast tomosynthesis, which we offer at all of our facilities, is a higher dose of radiation, but it does increase cancer detection rate, and it decreases false positives or callbacks compared to digital mammography. So those are two things that mammography is often criticized for, and digital breast tomosynthesis, or the 3D mammogram as it's called, does address some of those issues. It's a little bit increased cost, increased interpretation time for the radiologist, and then increased storage data. High-risk patients are another whole group. And what are the screening recommendations for the high-risk patient? And who are our high-risk patients? So first, we identify our high-risk patients. High-risk patients are those that have a known genetic mutation, or they are the untested first-degree relative of someone with a known genetic mutation. We hear a lot about BRCA1 and BRCA2. Those are the ones that have the highest risk. But there are other genes that are identified, including ATM, TP53, which is Lee Fermini, CHEK2, P10, CDH1, STK11, and PALB2. So all patients with those genetic mutations fall into that high risk group, or if they're an untested first degree relative. The next group of people that can be considered high risk are those that have a calculated lifetime risk of breast cancer of 20% or greater. And we use the Tyrer-Cuzick as probably the most comprehensive and most accurate of the risk assessment modules, although there are multiple modules out there. This is the one that we use when a patient comes to one of our facilities for screening. They answer a bunch of questions, and it actually will give a calculated risk to us as we're reading the mammogram. Also in the high risk category include patients that have a personal history of chest or mantle radiation at a young age, usually under 30, personal history of breast cancer and also dense breast tissue, and those that have a personal history of a high risk biopsy, either LCIS, atypical lobular hyperplasia, or atypical ductal hyperplasia. So this is our group of high-risk patients, and they have additional screening recommendations. So for our high-risk patient for mammogram, so annual screening mammogram is recommended to begin at the age of 30, which is earlier, if you're a patient with a known genetic mutation, or you're the untested first-degree relative of someone with a genetic mutation, or if you have that calculated lifetime risk of 20% or greater. In addition, women with a history of chest radiation prior to age 30 should begin annual screening mammogram 8 years after radiation therapy, or beginning at age 25, but whichever is later. High-risk patients are also recommended, high-risk screening is the same as for the average risk patient, digital mammo versus the 3D or the tomosynthesis. And again, tomosynthesis has an increased cancer detection rate and a decreased false positive rate compared to digital mammography with a little bit of increased radiation. Continuing on with high-risk screening, these patients also are recommended for adjunctive screening, and we recommend breast MRI. So contrast-enhanced breast MRI is more sensitive than either mammogram or ultrasound in high-risk populations. Contrast-enhanced MRI outperforms mammography and ultrasound even when they are used together. So recommendations for the adjunctive annual high-risk screening breast MRI. We recommend annual screening breast MRI beginning at the age of 25, so before the mammogram actually, in those that have that genetic mutation or are an untested first-degree relative, and those with a greater than 20% calculated lifetime risk, as well as those with a history of the chest radiation before age 30. Annual screening MRI is also recommended in patients with a personal history of breast cancer and dense breast tissue, and then also a personal history of breast cancer diagnosed before the age of 50. And ACR recommends considering adjunctive annual high-risk screening breast MRI for patients with a history of LCIS, ALH, and ADH. Screening breast ultrasound. So screening breast ultrasound has been shown to increase cancer detection. And if you review some of the literature after the Connecticut breast legislation and the Akron 6666 trial, basically it showed that adding screening whole breast ultrasound increased cancer detection rates between 3 and 4 per 1,000. And most of the cancers that were detected only by ultrasound were small and node negative. So it seems like a positive. However, the drawback to screening breast ultrasound is high increased false positives compared to digital mammogram, a lower positive predictive value, and a high recommendation for short-term follow-up, particularly at the onset. In addition, it's operator dependent if you're using handheld. It's time and labor intensive. And another plug for 3D or tomosynthesis mammogram is that if you're using digital breast tomosynthesis over just regular digital mammogram, the benefit of whole breast ultrasound is actually decreased, as about half of those cancers that were picked up on whole breast ultrasound will be picked up on the 3D mammogram. And the final caveat on that is if patient protocol, if they're in a high risk group, involves mammogram and MRI, then there's actually no incremental benefit of screening ultrasound, as the combination of mammogram and MRI is better. So ACR recommendations regarding screening breast ultrasound. We can consider screening breast ultrasound for a high-risk patient who would ordinarily qualify for adjunctive annual high-risk screening breast MRI, but cannot have it for various reasons, whether it's an implantable device, pacemaker, that's where you consider it. And then it can also be considered as an adjunctive for women with elevated risk of breast cancer simply based on their dense breast tissue. And then finally, additional screening with molecular breast imaging. Molecular breast imaging is actually a nuclear medicine study, relies on the injection of technetium-99, systemib, and then imaging on a breast-specific camera. It does have similar sensitivity and specificity to MRI for larger cancers. It's less for cancers under a centimeter, and it is not as good for ductal carcinoma in situ. It's not affected by breast density, but the drawbacks are it's a higher radiation dose, and it's whole body radiation exposure as opposed to just breast. So right now, there are no current screening applications recommended for this. So in summary, regarding screening, after a lot of those slides, the ACR recommends annual screening mammogram for average women to begin at age 40. High-risk women screening tools include mammogram and MRI as the mainstay. Digital breast tomosynthesis increases cancer detection rate and decreases false positives compared to our standard 2D. And high-risk patients can be referred to the high-risk clinic for evaluation and risk stratification. These are some of my resources. And these are my two favorite reasons to get breast cancer screening.
Mm-hmm. Thank you, Amanda. I think I'm up next. 2 seconds while I share my screen. Hold on.
And while you're doing that, I'll use this again as a moment to remind folks, if you have any questions, please, we'd love for you to engage. Please leave those questions in the chat box. You'll see the chat box there just at the bottom of your screen, and then we will answer those questions at the very end.
Okay, does it look good? Am I sharing?
Yes, we can see
Okay.
your screen.
Okay, thank you. Thank you, Dr. Caricato. That was a great discussion on the screening guidelines. And I think the take home of that, just to take it home, because there is a lot of confusion regarding screening guidelines for breast cancer guidelines and screening, and it's unfortunate. So age of 40 every year until age, we don't have an end age in the American College of Radiology, basically, as long as you're doing well and you're healthy. If you're 80, you still get a screening mammogram. So I'm going to kind of delve into some of these imaging modalities that she talked about as the screening test. So what's new in breast imaging? So it's not exactly new, but I would say at this point it is absolutely widespread. And it's digital breast tomosynthesis, which are just fancy word for what we all I think have come to learn as 3D mammography. It is done in conjunction with our routine 2D images that we've been obtaining for years, whether it was film or digital mammography. Next, I'm going to talk about some breast MRI, which is an incredible test with increased specificity. And she also touched on basically better outcomes and detection across the board for breast cancer, and especially useful in these high-risk screening populations. The newest update, which we are working on rolling out at Norton, but haven't quite yet because it just came out, is there is now an indication for what's called abbreviated breast MRI, which is just a shorter acquisition time, shorter table time, and is indicated now for intermediate risk women with dense breast tissue. So that's great news because ever since all the laws were passed in multiple states informing the women that they did indeed have breast heterogeneously or extremely dense breast tissue, I think women have become more educated with that knowledge, but then go to their primary care providers or their OBGYNs or whomever, and they say, well, now what? So I've gotten this letter that says I have dense breast tissue. What's the next test? And to this point, we really haven't had screening breast ultrasound has been one of them, but as she talked about, it's really not in widespread use. It has some drawbacks. And so this is going to be kind of the next, the test available for these women. So it's a big deal. Benefits of screening digital breast tomosynthesis or 3D. So this is huge. We both find it frustrating and makes it harder on us when some of these patients come in for their screening mammogram every year. They have dense breast tissue, and unfortunately, they just get a 2D mammogram. And so I think that we really want to drive home the importance of ordering for your patients a 3D mammogram or digital breast tomosynthesis. And educating patients on the benefit of those. The only drawback is increased radiation, and I'll talk about that in greater detail in a second. But as everything in medicine, it's a risk-benefit ratio. And so the risk, the benefit of 3D outweighs the risk of slightly increased radiation.
Your screen's not advancing.
Yeah, it looks like we might be stuck.
What's it still on?
I'm seeing just the beginning slide, that breast cancer screening guidelines slide. And it's actually Dr. Kirikato's slide there.
Okay, hold on. Let's see. Stop share. Let me do stop share real quick and then go to pull up my stuff.
Close mine out.
I'm going to close hers out. Hold on. Sorry, guys.
No worries, and apologies. I should have caught that, but I am joining everyone from my phone because I'm having technical issues today. So I saw a slide up, but I couldn't see that it was not yours.
No big deal. We'll get it just a second. Let's go to.
This is the fun of Zooming with everyone, right?
No.
The technology is not perfect.
I need to go to the Zoom thing. You can close that out. Here we are.
There
Say
you
share
are.
screen. Say share
Okay.
screen and then pull up my thing. Is that it? Is that
This
me?
is you.
There I am.
Okay, now go to make it bigger.
We want to go to
Slideshow.
slideshow.
Go to start.
Start. It's not. Oh, start. Here we go.
Do you see that now?
Can you see now?
Yes, we can. We see what's new in breast imaging.
Great. Okay. So I'll recap a little bit. So not really recap, but what's new in breast imaging? I'm going to talk about 3D mammography, breast MRI, and then the latest is abbreviated breast MRI. So it was actually only on the second slide. The benefits, these are huge, and I really think that it is really important for ordering providers to, honestly, I really think we should take a 2D order out of the system to even be ordered, unless it's a patient who really can't be still, is in a wheelchair or something like that. But the benefits of 3D are huge. So here is the breakdown. Basically, a 3D mammogram has a 41% increase in detecting invasive breast cancer. And so what we're talking about is all invasive breast cancers, but the most important caveat is that we are detecting smaller node negative breast cancer. So earlier stage breast cancers, which has huge prognostic implications and survival benefits for these patients. Less treatment, less all of the above. It has a 29% increase in the detection of all breast cancers. The difference in this invasive versus all breast cancers is that it doesn't actually help us detect ductal carcinoma in situ, but it is mostly increasing our detection of invasive, like stage 1 node negative breast cancers, which is a huge deal though. Essentially 3 additional cancers are detected per 1,000 when you add 3D digital breast tomosynthesis to a 2D mammogram. The other huge benefit is a 15% decrease in recall rate. So for your patients, this is a huge anxiety producing when they go in, they get their screening mammogram, and then they get a letter saying you've got to come back. So 3D mammography essentially allows us to decrease that callback rate, which is huge for these women. So many women who are used to getting called back because they have dense or complicated mammograms or complex mammograms, we are now able to say, oh, that's just normal tissue, because we can scroll through our multiple images of 3D and say, okay, that's just normal tissue, rather than artifact that we just on a 2D can't really discern as normal. The other benefits of 3D mammography are it has improved localization of the lesion. So in 2D, when we only had 2D, if we only see something on one view, it was sometimes hard for us to decide what quadrant of the breast it was in. And now with the advent of 3D, we now can scroll through those images. And even if I can only see it on one view, I am able to determine which slice I can see it on. And I know whether it is more likely to be in the lateral or the medial breast or the superior or inferior, based on those images. Lastly, it has improved characterization of the lesion, gives us better details about the degree of architectural distortion surrounding tissues, the margins of the mass or lesion, associated calcifications and such. Again, this is just a recap, but basically it decreases our false positive rate, which everybody loves that in medicine. It increases our cancer detection rate by at least a third, depending on what trial you look at. Increases our positive predictive value, and the positive predictive value continues to improve with digital breast tomosynthesis for at least 3 years for patients. So it basically, there's literally no downside except for minimally increased dose of radiation. Huge upsides. It does benefit all densities of breast tissue, whether it's fatty, scattered. We characterize breast density into fatty, scattered, heterogeneously, or extremely dense breast tissue. It benefits all densities, but there is a greater benefit in women with dense breast tissue. So the screening exam method that is currently used at Norton, we do 2D, a standard 2D mammogram, plus the 3D or digital breast tomosynthesis. You have to do both. You don't just do a 2D unless, like I said, there's caveats. There are patients who, can't tolerate an additional picture. You do have to breath hold for it, but it's very quick. It's like less than 15 seconds. And really pretty well tolerated. Most patients don't even notice a difference with the 3D mammogram than their 2D mammogram. Norton currently uses this rather than the synthetic view. I don't really want to get into the synthetic view because it can kind of be confusing, but it is basically just a non-standard 2D view. We are still using standard 2D views. So digital breast tomosynthesis uses the same for standard views as 2D mammography, which are craniocaudal, right and left, and mediolateral oblique, right and left views. So each of those views with a 3D has approximately 40 images per view. That's a standard patient. So obviously with a larger breasted patient, then they're going to be more than 40. So that's 160 images roughly per patient. It is all of these are read in combination with CAD, which just stands for computer aided detection. That's been around for years, and that just helps detect calcifications and abnormalities on the mammogram. So let's talk about radiation dose, because that is the only concern really that I've heard from patients. And like I said, it's typically more educated patients. And so they say, well, why do I need a 3D? I had a 2D last year and it was just fine. And I don't really want the increased radiation. Well, here's the breakdown. So when we talk about a radiation dose on these patients, this is on an average patient. So a mean glandular dose per view with 4.5 centimeters of compressed breast, approximately 50% glandular and 50% adipose tissue. The MQSA, which is our regulatory body, regulates that we have less than 3 milligrays per mammogram, screening mammogram on a patient. So a 2D has 1.2 milligrays, a 3D or digital breast tomosynthesis has 1.45. So the standard combo view, which is what we do on these patients, is a 2.65 milligray, which is under our 3 milligray. So just in reference, patients or people in general receive background radiation of approximately 3 milligrays a year, literally just by walking around outside, being on the earth. Cross-country flight is approximately 10 millirems. We know that you have to have at the least 100 millisieverts or milligray to even start to talk about increasing your cancer risk. And that's really, we know that 1,000 is 1,000 millisieverts or milligray is associated with fatal cancer. So we're talking minimal radiation, which most people are getting background. And so again, the benefits of digital breast tomosynthesis greatly outweigh the risk of radiation. So a big question that I also hear from patients, other than radiation, probably more than radiation, is my insurance going to cover it? And unfortunately, we are still at a couple of our sites still asking patients, to sign this waiver on whether or not their insurance will cover it, and they'll pick up the bottom. They'll pick up the tab if it doesn't. And I'm trying to get that to go away because it's really irrelevant at this point. And I think it is just confusing to patients. And it was relevant in 2015 when we rolled out digital breast tomosynthesis. Most private payers were not covering it. CMS or Medicare had not said they were going to cover it. And they, I think as of 2015, did say that they would, they now have a code and they now cover it under their preventative care and screening guidelines for patients. So in the state of Kentucky, we were actually one of the first states, I think in the year 2017, that mandated private payers cover 3D mammography. Kentucky Medicaid covers 3D mammography or digital breast tomosynthesis. Indiana Medicaid covers it. I do think with Indiana, you have to actually get your test in Indiana. They have a little bit more stricter guidelines, at least, definitely for MRIs. But at this point, it's covered by virtually everyone. So it's kind of a moot point to talk about coverage or payment, at least for screening test. Does Norton offer digital breast tomosynthesis or 3D mammography at all of their sites? Yes, we are excited to tell you that we offer at all three of our main breast centers: Norton Brownsboro Breast Center, which is outpatient, Norton Pavilion Breast Center downtown, and Norton Women's and Children's Hospitals. Every single unit, with the exception of one of our units downtown. So that is 4, 8, that's like 10, we're talking 12, almost 12 units are digital breast tomosynthesis at these, at all of our sites. So also the off-sites, the OBGYN offices offer also 3D digital breast tomosynthesis. Norton Hospital has 2 units. One is digital breast tomosynthesis enabled and one is not. And the most exciting news is that Norton has 2 mobile units now. We just have a brand new mobile unit as of this summer. It's been a little bit off kilter with our mobile unit schedule because of the pandemic, but we are officially up and running as of last month. And it does offer 3D mammography or digital breast tomosynthesis. And we have a pretty robust schedule in the upcoming months because it's Breast Cancer Awareness Month, October right now, and also through the end of the year. I just briefly looked at the website, and just for instance, it is going to the Family Healthcare Health Center in Fairdale, October 20th, Family Health Clinic or Center in Americana on the 21st. It'll be at Kroger's in New Albany on the 22nd, the Catholic Enrichment Center on Broadway. It'll be at CMA on Broadway, November 3rd. Shively on the November 10th. It is virtually all over downtown. It is over the, it is in South Louisville. It is across the bridge. We even have a lump and bump clinic now at 7th and Hill. From 10 to 2 on Fridays. So if you have patients who are feeling something, they can be sent there. Lastly, just a few slides on digital breast tomosynthesis. So this patient, it's hard for me to really convey how much better 3D is because it requires so much memory. And as we scroll through the images, it's hard for me to show that on a PowerPoint slide, but just take my word for it. This is a 53-year-old asymptomatic screening. These are 2D views. This is a right CC, left CC, right MLO and left MLO. CC stands for cranial caudal. So this breast is compressed from top to bottom, just kind of goes into the unit. And this is medial lateral oblique is what MLO stands for. And so it is obliqued. The X-ray tube is obliqued with regard to the pectoralis major muscle. So this is nipple, this is chest wall, this is chest wall, and this is nipple. So those are the 4 views. And then we do those same 4 views in 3D. And on the left on that patient, in the medial and inferior left breast, kind of hard for you all to appreciate it. These images kind of look fuzzy, but as we scroll through, we can see that there's a focal asymmetry and some architectural distortion there, which is much better picked up. Architectural distortion is one of the things we look for when we are looking for breast cancer. And it is really well seen on 3D mammography. And so these are her spot views from her diagnostic mammogram when she came back in that confirms. You can see architectural distortion is essentially when we have pulling in of the tissue. Normal breast tissue should all flow towards the nipple. Here's your nipple. So it should all flow towards the nipple. And when tissue is going the opposite way or towards a central nidus, then we get worried that there may be a cancer growing there. It essentially is the imaging equivalent of the desmoplastic response to cancer in a patient's body. You can also see architectural distortion with post-surgical change and things that are not cancer, but it's a reaction in your body. So this is the corresponding ultrasound that she then had, which shows this irregular hypoechoic shadowing mass with irregular margins. It got some angular margins. This is an ugly cancer. And then the corresponding MRI, this is her right breast and her left breast. This is the area what we would call non-mass enhancement. And this ended up being an invasive lobular carcinoma, grade 2, a 4 millimeter cancer. Again, the size, if you can appreciate this, so see how dense this patient's breast tissue is? The way it was really detected on mammography was most likely because she had 3D. On 2D, you could say, oh, is that a cancer? Is that a cancer? All of this looks very similar, but on 3D, as you scroll through, and you can see on a few contiguous slices that this was definitely all being pulled in and this true architectural distortion. And then on MRI, I think you can appreciate that even though she's dense, the thing that is bright white is what is enhancing. And so essentially in MRI, the density goes away. And so that's the major benefit of MRI is that even with really dense breast tissue, as a physiologic exam. And so cancers pick up the contrast really quickly and then also spit it out really quickly just because of the neovascularity and leaky capillaries and vessels and such. So we are able to better detect the tumor size too. So you're more accurately able to detect tumor size here as a 4 centimeter cancer, which helps helps them determine the treatment plan for this patient. So is another case of just really subtle architectural distortion. This is the 2D images. Actually, these are synthetic views, but synthetic 2D views, but this is a really subtle area of architectural distortion magged up here where everything is pulling in right here. And that is going to be on 3D. It's again fuzzy, but on our images, it would not look fuzzy. It would be a sharp focal area of architectural distortion. And that's going to be a stage 1 invasive lobular carcinoma. And that patient's going to do incredibly well because her cancer has been picked up so early with the advent of 3D. Okay, next, moving on to diagnostic breast MRI. Breast MRI volume at Norton has increased by over 50% just in the last year. And that's very exciting because it is an excellent test. And I'll go over the indications for breast MRI. The acquisition time is approximately 20 minutes of table time. So it's really not a long examination, but if you have patients who are claustrophobic or think they can't tolerate it, really 5 milligrams of Valium goes a long way. I highly recommend dosing those women with 1 tablet of Valium, and they can do fine because it's just such an exceptional exam. Contrast is necessary. There is no radiation in breast MRI, but they do have to receive contrast, and with the exception of when patients have implants, and then implant integrity MRI does not need contrast. So diagnostic breast MRI is offered at 5 sites currently. We do it at Brownsboro Outpatient Breast Center, across from the Norton Cancer Institute. We also offer it at Brownsboro Hospital. A little caveat for you, for your patients that are larger BMI, the largest coil in our system, our largest magnet that can accommodate patients of size is at Brownsboro Hospital. So if your schedulers, if you want to assist in that, that is just something just to know. Norton Hospital Downtown has a breast coil. Norton Women's and Children's has a brand new one up and running. And then also we are starting to roll it out at a Norton Fern Creek outpatient site. I'm not sure of the schedule, but that has just recently been at least trialed and tested in the last month. The indications for breast MRI are the following. So breast cancer screening in high-risk women, which Dr. Caricato talked on spoke about, and basically over the age of 25. So this is the first test you can get if you are high risk, not a mammogram, but a breast MRI at the age of 25. And so we at Norton's have a really, really robust high risk screening program at this point, and some excellent nurse practitioners at our high risk clinics who have really increased the screening of this population. And so we're really excited to announce that. The next indication for breast MRI, which is also part of why our volume is increasing, the surgeons and oncologists are really at this point understanding the benefits of breast MRI and evaluating patients who are newly diagnosed with breast cancer, especially in dense breasted patients, but in all patients, and evaluating for what we call extent of disease, or a preoperative evaluation, where we look for satellite lesions. Multifocal, multicentric disease is the fancy word for that. But basically, we found your tumor in your left breast and upper outer quadrant. Now let's make sure that there's not a smaller lesion, in that same quadrant, or possibly disease in another quadrant of your breast, or also cancer in your contralateral breast. And that is all evaluated on a breast MRI. Another indication is for a patient undergoing neoadjuvant chemotherapy. The oncologist feels like it doesn't seem like their chemotherapy or the drugs I'm giving this patient are really working, that we can do a breast MRI. It's ideal if those patients have had a pre-treatment breast MRI and then have a mid-treatment, MRI, and we can actually calculate the functional tumor volume based on the enhancement. And really, the trials are showing pretty promising results on the prognosis of these patients, survival, and response to chemotherapy. We don't use this a lot because you also can assess response to neoadjuvant chemotherapy clinically, because most of the patients who receive neoadjuvant chemotherapy have a pretty sizable, palpable tumor. But that is another indication. Evaluation of breast cancer patients with positive surgical margins following breast conservation therapy. So we usually have to wait about 6 weeks before we do an MRI on those patients, but that is an indication. Evaluation of patients in metastatic axillary lymphadenopathy with an unknown primary. So despite all of the advances in mammography with 3D and digital breast tomosynthesis, there is still approximately at least 15% of breast cancer that is considered to be occult on mammography, meaning they present with a lymph node that's positive, it's enlarged, and we didn't see their breast cancer on their mammogram or sometimes even on ultrasound. And so this is breast MRI is indicated in those patients to find that occult malignant breast tumor. We see a couple of those a year, I'd say. Lastly, we can use it as a problem-solving tool for equivocal mammographic findings. I'm just going to touch, this is not an indication per the American Cancer Society or ACR at this point for MRI. However, in our literature, this is quickly replaced galactography in patients with nipple discharge. And we do see a lot of these patients in our practice that are sent for a diagnostic mammogram because they've got nipple discharge. So just a little education point. The only nipple discharge that we consider to be worrisome or pathologic is spontaneous. They do not have to express it. Most patients that we see in our practice that complain of nipple discharge, if you ask them if it's expressed or they have to squeeze their breast to elicit the nipple discharge, they will most likely answer yes. If it is expressed, it is not considered worrisome. So we are only worried about spontaneous, single duct, unilateral, bloody, or clear discharge. We're not worried about milky, green, blue, the rainbow, which sounds crazy, but that is typically associated with fibrocystic disease or fibrocystic change. Bloody or clear, though, single duct, spontaneous, is considered pathologic. The test of choice for those patients with the highest sensitivity of detecting an abnormality, such as a papilloma or breast cancer, which are the most worrisome things we see in these patients, is a breast MRI. So just a little caveat, galactography is no longer performed at Norton facility, or honestly, I'm not sure where in Kentucky it even is performed. So just a little caveat on the high risk program. We have 2 high risk clinics, Norton Women's and Children's and at Norton Brownsboro Breast Center. These nurse practitioners are excellent in assessing these patients' needs, accurately calculating their lifetime risk. Dr. Caricato talked about that. Tarakuzik version 8 is the most robust module that we have, and assessing their need for a screening breast MRI. These patients can actually self-refer to these clinics, or you can send any of these patients to them, just refer through Epic. And then I have some phone numbers for both of those. Genetic counseling is offered at both of these high-risk clinics, and genetic counseling is also offered at Norton Pavilion. Also, genetic counseling at this time through Norton is offered via Zoom calls or telehealth visits, so patients don't even have to come in for that. So that's excellent. But these high-risk nurse practitioners that see these patients are the ones who are really well equipped to decide whether the patients actually then need to go on for genetic counseling and or genetic testing. One of the things that they are great at is calculating these patients' lifetime risk the most very accurately, and coding for these breast MRIs, so these patients will have a breast MRI paid for by their insurance and or Medicare. Sometimes it's hard for the primary care providers to, sift through all those details and provide enough evidence to prove that these patients really do need a breast MRI. And these nurse practitioners are excellent at really digging into those histories and getting these tests paid for when these patients really do need them. Newly diagnosed breast cancer. So when we do a breast MRI on these patients, when combined with mammography and a clinical breast examination, has been shown to provide 99% sensitivity in adequately and accurately providing the preoperative assessment and the local extent of disease. So in that case, like earlier, it looked like she maybe had a 1 centimeter mass, and it turns out she had, actually, no, I haven't got shown that yet. Sorry, I'll show that in a second. It's going to show you that we have lots of disease in some of these breasts. It detects additional unsuspected malignancy in the ipsilateral or same breast up to 1/3 of the time. And also detects it in the contralateral breast less than 10% of the time, but approximately 3 to 7%, depending on which trial you read. Tumor size is more accurately depicted with MRI versus mammography when correlated with pathologic specimens. The long-term goals of breast MRI, while we don't have the data at this time to data yet to prove these are the long-term goals, and eventually I think we will have the data to prove these. So the goal is to decrease the number of surgeries required to obtain negative surgical margins in these breast cancer patients, to decrease breast cancer recurrent rates, and to improve long-term survival. I think improving long-term survival is everybody's ultimate goal on the breast cancer teams. And particularly helpful, we've already touched on this, but patients with dense breast tissue, invasive lobular carcinoma. Lobular carcinoma is the cancer, unlike ductal carcinoma, is more difficult for us as radiologists to detect. It kind of grows in what we call a single file line and doesn't always form a mass or a tumor, and kind of just is sneakily grows along the normal stroma of the breast. And so it's harder for us to see that on a mammogram, but better seen and depicted on MRI. Patients with extensive ductal carcinoma in situ, MRI is very helpful, and then patients requiring neoadjuvant chemotherapy. So this is just an example. So we talk about how density is not relevant or always confers to difficulties in breast MRI. And so we always talk about breast MRI, the patient's background parenchymal enhancement. That's just a fancy word for how much did their breast take up normal contrast, normal breast tissue, hormonally active breast tissue. And so the top left here would be minimal background enhancement, mild, moderate, and then marked. And so the one with marked does limit our sensitivity and specificity of our examination. So I'm going to speed up. I think we're about to run out of time here. Just to show you all, though, that really a patient with really dense breast tissue, if I had a little mammogram over here, this patient may have heterogeneously or extremely dense breast tissue, and then you go get the MRI, and that density essentially melts away. And these are normal vessels. This is nipple, this is nipple, this is right breast, left breast. These patients are laying on their stomach in a prone position, and we can see right through that density and see what is enhancing, because this is like a cytophysiologic test in which we have we demonstrate things that are enhancing or uptaking contrast, and cancer uptakes that at a really quick rate. This is a newly diagnosed right breast cancer. So you can see all this normal tissue around here, and this is your irregular enhancing mass. And in this patient, we can confirm that this indeed is the accurate size of the tumor and the only tumor in that breast. Next is a patient this is our mammogram, and she was called back for some architectural distortion. That's pretty ugly right here. We would call focal asymmetry, architectural distortion, some tenting or pulling of this nipple. On ultrasound, it looked like you have about a little over a centimeter, 1.5 centimeter tumor that is this indistinct shadowing tumor. And then unfortunately, she has an MRI. This is her right breast, left breast on the 3D MIP. And this is an image of just the right. And you can see that this is what we thought was originally the cancer, but it turns out she has multiple little foci all in her medial breast. Basically, virtually throughout this entire breast has cancer, which was occult. On the inferior part of this mammogram, you don't see any. You would not know that these little foci down here are malignant, when in fact on the MRI it's really obvious. So this whole bright breast has filled with cancer. So this patient, instead of getting a breast conservation therapy or lumpectomy, will now go to a mastectomy and have the appropriate surgery. When potentially the next year on our mammogram, this stuff in the inferior and medial breast would have been larger, and then she would have been diagnosed with breast cancer and say a year after her original breast cancer, which, we used to think potentially was a recurrence, but we now know was a synchronous cancer, just undetected at the time of original diagnosis. So the newest test is what's called an abbreviated MRI. It's just a shortened protocol. It's really, most protocols are less than 10 minutes of table time, which is huge. We do give contrast, but we just omit some of the other sequences that we use on a standard diagnostic MRI. So on high-risk patients, we still recommend the full diagnostic MRI at this time. So this is available for patients with, it's not available at this moment, but is recommended, but we are working on, stay tuned. It'll be available soon, but reduced table time, acquisition time, and reduced reading time on the radiologist part. But it is indicated for intermediate risk women, so under 20% lifetime risk of developing breast cancer, and dense breast tissue. So huge for that population of women. These are my citations. I don't have any pictures of my cute kids, but thank you all for your attention. We appreciate it.
Thank you so much, Dr. Callahan and Dr. Curicato. It appears that we may have some additional questions that were not answered. Correct me if I'm wrong. I know you addressed some during your presentation. So it looks like we have a question here. Should the thyroid be covered during 3D mammograms?
No. We don't cover the thyroid during 3D mammogram. No, I mean, the scatter is reduced.
Yeah, it is not. That is not indicated. It is offered. If we have patients who request it, certainly we can provide a thyroid shield, but that is not universally used or indicated.
And then we have another question here. Can you comment on appropriate imaging for palpable masses, tender versus non-tender in teens 20 years old without a family history of breast cancer? Also, can you comment on appropriate imaging in men with a palpable breast mass, 2D versus 3D?
I'll take the 20-year-old and you can take the male. Sure. So in a 20-year-old palpable area of concern, we would start with an ultrasound. Mammography is not indicated for a 20-year-old. Over 30-year-old with a palpable area of concern, a mammogram is recommended in conjunction with an ultrasound. 30 to 35 is a little bit of a gray zone, but in our practice, we feel like it is necessary for a mammogram at that time. So we would do a bilateral diagnostic mammogram. So we have an internal comparison, even on the non-symptomatic side, and an ultrasound. And also Dr. Caricato and I both on a palpable abnormality, always go in, examine those patients, feel the abnormality, do a clinical breast exam ourselves, and an ultrasound by our technologist and us. And then on a male patient,
On male patients, we actually only do 2D mammogram to start with. So if we have a male patient that comes with a palpable abnormality or a problem visit, because the male breast is predominantly fatty or placed, and they don't have that volume of breast tissue, we just actually do just a standard CC and MLO views bilaterally. And if we need to move to ultrasound, then we go from there.
And I think you said tenderness too. So I'll just touch on breast pain, because we do see a lot of patients with breast pain. Diffuse breast pain is considered physiologic, normal, hormonal, really no matter your age, diffuse breast pain. And imaging is not indicated in those patients or in that patient population. However, focal breast pain, although very rarely associated with breast cancer, it is indicated to have a diagnostic mammogram and ultrasound of the focal area of pain in an over 30-year-old, and in an under 30-year-old, we would just do an ultrasound of that area. We also typically give patients with breast pain an education sheet, talking to them about reducing caffeine. There are some anecdotal things that you can take for breast pain, vitamin E, things like that. And so we try to educate those patients too.
Okay, I think that may be it for all of our questions. Thank you all so much. This was very informative, a very interesting talk. I really appreciate it. Enjoyed the photos of your children, and those flowers behind you are very beautiful, those roses. Before everyone leaves us today, again, please remember to complete that evaluation. You will need to do so to receive your credit for today's CME. That QR code will appear on your screen here shortly. You can scan that. A link will also be shared with a link to a Survey Monkey survey. You can just complete the evaluation there if you prefer. We do hope that you'll join us for our next CME, our next updates in women's health. It's going to be held November 10th, and we are going to be hearing from Dr. Kendall Stevens and Dr. Jennifer Willis. They're going to be discussing diabetes in pregnancy. So we hope to see you again. Thanks, everybody. We hope you have a great week.
Lastly, I think I was supposed to say I have a disclosure with Hologic. I think it was mentioned on my original paperwork, but as a consultant. So I don't think I even mentioned Hologic today, so it doesn't matter. But yes.
Thanks for getting that in there. You can never be.
All right, got that disclosure.
Yeah, there we go. We can check that off. Well, thanks, everybody. Really appreciate it. I hope everyone enjoys the rest of their day.